Got it. Okay.
Okay, perfect. You're good. Thank you.
Good. So yeah, we'll just start out here, just talking a little bit about kind of where to go from here. So, you know, um, Dr. Tarabici, Professor Tarabici was one of the first people to do endoscopic management of cholesteatoma. And that was even back in the 1990s. I remember talking to Dennis Poe, who works in Boston, who does a lot of work with eustachian tube dilation. Dennis actually says in the 1980s, he spent a lot of time doing endoscopic procedures on the ear, and he kind of abandoned it because he didn't feel like at the time it was providing that much benefit for him. But he says, no, I did it all in the 80s and I kind of left it behind. So there's definitely been some improvements in instrumentation. For example, some of the sizes of the scopes and some of the understanding. I think endoscopic visualization equipment is better. The HD systems are better. There's no question we're getting better visualization than was done back then. But even in the 90s, Professor Tarabici was talking about doing transcanal endoscopic ear surgery with limited attic involvement. And so this study he did back in 1997 showed that 36 patients out of 38 with acquired cholesteatoma underwent a transcanal endoscopic ear surgery. Most of them were disease-free at 1 year, 10 out of 13 disease-free at 2 years, which is, that's about standard. I mean, those results are pretty typical for microscopic management as well. And his conclusion was that transcanal endoscopic resection of cholesteatoma is safe and effective. I would say that's true. I think you should definitely consider the extent of the attic disease. If you think that, and we'll talk about this more as this talk goes on, but if you really believe that the disease is posterior to the lateral semicircular canal, then you probably should consider a hybrid procedure with a microscope and an endoscope. You're probably going to have difficulty doing a purely endoscopic procedure for disease that goes posterior to the lateral semicircular canal. I have done it purely endoscopically. Sometimes you get it, you get that last piece out of the antrum and there's nice mucosa under it and you feel that you got a good clean resection. But I've converted many cases that went posterior to the lateral semicircular canal, especially when it involves a coating of sac that's up in the antrum. It's difficult to clear that disease with an endoscope. And I've spent a fair amount of time trying to do it. And my rule is if I look at a preoperative CT or if I really think that someone's got disease posterior to the lateral semicircular canal, I plan on doing a combined procedure with an endoscope and a microscope. I don't think that I'm going to be able to do that all endoscopically. If the disease is limited, if it goes up to the lateral canal only, or it's attic only, then certainly an endoscope is probably going to be able to manage that disease. You could also manage it with a microscope and do an atticotomy, endoral procedure, limited incisions. There's a lot of ways of doing it. And I think what endoscopic surgery has helped us to learn is that there's always been more than one way of doing an ear operation. There's been, you can go post-auricular, you can do endoral, transcanal. Now we have an endoscope. But I think what it does is gives you another tool. It does improve visualization in certain situations, but it's not the answer to disease that goes into the mastoid. It's not. And so I think that just, and this is for those of us who have been doing this for a while, and I'm certainly not the person who's been doing this the longest, you learn pretty quickly what kind of diseases you can manage and which ones you can't. I think for middle ear disease, like posterior recess disease, limited to the middle ear, or Prussic cholesteatoma, I think it's fantastic. I think it's a fantastic technique, and you get such a good view, even with a 0-degree endoscope. You get a very good view of the posterior recesses. You don't even have to use a 30-degree or 45. And I'll show some demonstrations of that. But it's good for middle ear disease, definitely. What basically, the other thing that Professor Tarabici concluded was that basically we learn a lot about how cholesteatomas travel, kind of how they go and which ways they can go. And I think it's contributed a lot to understanding anatomy and pathophysiology of cholesteatoma. Certainly you start learning, like, the textbooks always show the ways that the cholesteatomas can travel. And you start with an endoscope, you can kind of see some of these pathways. You definitely get to see the membranes of the middle ear better. When you're doing, like, for example, when you're lifting up a drum on a more normal ear, let's say you're doing it for an ossicular fixation or something with an endoscope, you see all those membranes you can see in the textbook that you really don't see very well when you're using a microscope. You can see all those pathways really well. And so it's definitely a good learning tool. So some of the advantages versus disadvantages of endoscopy versus microscopy, I think these can be overstated a little bit, but I think that definitely endoscopic surgery is a one-handed operation, and that limits what you can do. I mean, using an endoscope holder is not really feasible. And we're not going to talk about exoscopes today, sort of the bigger scopes that sit farther back, but endoscopy is really a one-handed operation. So that limits what you can do. For example, if you want to do your stapedectomies with one hand, you can. My argument would be, why do you want to do a stapedectomy with one hand? But there are many people who do, and there have been papers published saying that the results are similar. I don't think the results are superior using an endoscope, and so if someone were to try to claim that, I would challenge them on that, because I don't think that's the case. But definitely, I don't, for example, personally, I don't do stapedectomies with an endoscope, but that's the way, I like doing stapedectomies with two hands. Richard, did you raise your hand?
We have somebody who's trying to get in.
Oh, okay. Let me just pull it up. Got it.
Thanks.
Okay. And so the other things are, we mentioned different approaches you can use with a microscope or an endoscope. You can do combined procedures with an endoscope. The resolution is very, very good, especially with newer equipment. I mean, endoscopic views are amazing. You do get a binocular view with a microscope that you don't get with an endoscope, although I don't think that's extremely helpful, except for potentially in stapedectomy, although I think when you're dealing with looking at the disease at a very close level, then the advantage of binaural vision doesn't really stand up as much. It's not as important. You definitely get the ability to look around corners, although the inspecting around a corner is different than trying to dissect disease around a corner. And that's what you'll learn when you start doing this, is that certainly checking that antrum with a scope is great, especially if it's clean. But if you see disease there, you can use curved sections and curved instruments and try to clear disease. And as long as it's, like I said, if it's near the lateral canal, you can do it. If it goes much farther back, depending on the adherence of the disease and how long it's been there, it can be very challenging. So I like doing hybrid surgery with disease that goes into the mastoid. So just kind of some principles. So endoscopic or ear surgery is about having tools. We all know that. You want to have as many tools as you can. You want to be familiar with different approaches. There's not one right or wrong way of doing it. If you don't know how to do something, you can't use it. So that includes endoscopic procedures or endoral surgery or things that, other than post-auricular approaches that we all learn. If you don't know a tool, you don't know how to use something, you don't have it in your bag. So it really benefits you to train with different people, observe different people, learn different techniques. The endoscope is just another tool. And one of the things you'll read a lot about in endoscopic papers is this concept of, well, you can spare the patient an incision and spare them a mastodectomy using an endoscope. Well, there's other techniques that will do that too. Endoral surgery does that too. So, and endoral surgery has been around a long time. And so, let's just put it this way. If you think the only way to get into an ear is to make a post-auricular incision, you need to read more textbooks or observe more people doing different kinds of surgery, because an endoscope is not the only way to spare someone an incision or a mastodectomy. Okay, so it behooves every ear surgeon to learn endoral procedures, for example, endoral techniques, because those can be extremely valuable, and they can do the same thing in terms of sparing the patient an incision. Okay, so I encourage you to the book here by Toss about endoral surgery. As I mentioned, this is a very, very valuable textbook if you want to learn about endoral procedures. Many of them are very valuable even with an endoscope. You're going to be combining techniques as you do this. For example, attic reconstruction. Most of the literature on attic reconstruction after you have a defect there is from the endoral literature. So you better read it, because if you want to know how to reconstruct an attic when there's a large defect there, you need to look at endoral techniques, because those have always done created attic defects and reconstructed them. So this is probably the best one single source textbook to learn about endoral, especially attic reconstruction. So taking cartilage, fascia, perichondrium, and reconstructing the attic with different techniques, how to make different incisions in the ear canal for different types of disease. That's all in this book. The other thing I really like for endoral surgery is these are Stort's retractors. They're the two-prong endoral retractors, and they're really the only two-prong small endoral retractors that you can find from any manufacturer. And I think these are useful also for just pediatric cholesteatoma surgery, even post-auricular. These are just really useful retractors to have. So if you're going to invest in some endoral, products, I would just say the primary thing you should get is a good set of endoral retractors. And this is the Stort's. It's got the part numbers. The N one is actually, it's a dark coated, so it doesn't reflect the microscope light back in your eye. So those are the ones I have. They're the 220213N. So if you're interested in, and you can use these for endoscopic procedures too. Sometimes in a smaller canal, you're going to make an endoral incision and put a retractor in, and then bring your endoscope in. So again, you can use hybrid techniques here. Don't think of this as one technique. Think of it as just another tool. So here's some different studies on different types of disease, on with different approaches. We're using either an endoscope or a microscope, and for the most part, endoscope. The argument is maybe quality of life could be a little bit better because you're avoiding an incision, but again, an endoscope is not the only way to avoid an incision. I think that outcomes with stapedectomy, chronic ear disease, ossicular reconstruction are similar. So I don't think we should be focusing on results to try to say that one technique is better than the other. I think what we should be focusing on is, how often does a procedure need to be converted to a microscopic procedure? How many procedures of yours were you able to do with a single technique versus a combined technique? How can you predict whether someone's going to need an endoscopic surgery or a microscopic surgery, for example, on extent of disease? Those are the kind of things I think we should be focusing on rather than trying to study outcomes, because even going back many years with standard ear techniques, the outcomes are the same. We don't see outcome differences between undersurface grafting, lateral grafting for tympanoplasty. We don't see a lot of difference between using, titanium prostheses versus porous polyethylene or other kinds of OCR. There's not a lot of difference there in terms of outcomes. So I think that for example, I think the things that are important is if you look at someone's ear canal in the office and it's fairly small ear canal, what does that make you think? I mean, does that make you think you're going to be able to use an endoscope because it's a small canal and an endoscope will be better? Well, my answer would be no, because small ear canals are actually not good cases for endoscopes, because a small ear canal needs a canalplasty. An endoscope is not going to get you to do what you need to do in a small canal. So I think people think, well, small anatomy, I'll just bring the scope in. And you'll learn pretty quickly that an endoscope doesn't get you around the problem of small anatomy or small access. It improves your visualization once you're there, but it doesn't get you around the problem of small corridors to where you're going. So if you look at someone's ear and you say, man, that's a small canal, well, you're probably going to have to do a canalplasty on that patient. And so even with an endoscope, for example, recently I had a tympanoplasty for an anterior perforation, and I wanted to use an endoscope, but there was a very large hump. But you can bring a drill in, even with the endoscope, you can intermittently irrigate, and you can do some limited anterior canalplasty with a drill, even with an endoscope. Is it ideal? No, but it's reasonable to do. You can also use an endoral technique or another technique to do that. So the problem I think people put themselves in with endoscopic surgery is they start thinking, well, I'm going to do everything with an endoscope. And there have been people, there's a person who's no longer alive who was a very big proponent of using an endoscope for everything. And his argument was, you have to use an endoscope. You shouldn't be using anything else. And I think that's not really the right attitude we should be having. We should be figuring out when is it appropriate to use one thing versus another, and just training people to use different techniques. But I think as I mentioned, there's a big role for learning traditional endoral techniques and traditional attic reconstruction, because if you know how to do those, then you're going to be a better endoscopic surgeon when it comes time to doing the recon. So about instrumentation, about endoscopic procedures for nasal surgery and sinus surgery. So about cameras, about light sources, about monitors, things like that. You want to get the best equipment you can. You're going to use standard otologic instruments, the same things we use all the time. And then you do need to use epinephrine with an endoscopic case. So you have to be comfortable. Let me just admit everybody here again. You have to become comfortable using plain 1 to 1,000 epinephrine on cottonoids, because you do need to do a canal injection with lidocaine with epinephrine, just like you do for any other case. You can't just use topical anesthesia. You have to inject the canal. But when you're lifting the flaps, you're going to get bleeding, and especially in the middle ear, you have to get comfortable with putting plain epinephrine on a cottonoid and using that for hemostasis. And the cottonoids that I recommend are the 1/4 by 1/4 inch. Codman is a company that makes neuropatties, the small cottonoids. I find those are the best ones. They have a single tail. You don't cut off the tail, so leave the tails on. You don't want to lose patties in the ear. Okay, so you want to leave the tails on and you use them with epi. You put them in, you wait a minute, then you take them out. And 1/4 by 1/4 inch is really the best size. There are bigger ones, but I've tried several, and I think that's the best size to use. And I recommend only opening the epinephrine on the field once you've done injecting. So just for patient safety, when you've done the canal injection at the beginning with your lidocaine with 1 to 100,000 epinephrine, get that done, and then have the nurse open up the epinephrine, ampule, and put your patties in it. But don't bring on the epinephrine plain on the field before you've injected, because I know of at least one doctor who's injected plain epi, and you don't want to, 1 to 1,000. You don't want to do that. So it's kind of a process in your OR. You should do your local injection, and then you bring your epi on the field after that. It's just a good practice to get into. That way you don't end up with any, improper injections. Here's the Storz set. Now, as I mentioned, you don't have to buy. In fact, I recommend not buying this set, because look at all these curved sections on here. I mean, wow, it's amazing. There's 12 of them. You don't need 12 curved sections. You might need 1 or 2. You don't need, and a lot of the instrumentation on here is redundant from what you already have. I'll show you a couple of other ones that you should get. I mentioned the end-oral retractors. These are Storz dissectors called Thomason dissectors. And these are very useful for endoscopic surgery. So they're kind of like a hockey stick, a right angle, but they have a sharp edge on the end and they're curved slightly. So it's different than a Crabtree or a hockey stick. And there's about 3 different lengths. There's 2 different lengths, and then there's one that also has a curette on the end. If you're going to buy any instrument for endoscopic surgery beyond what you already have, these are what I would get. And you'll see these mentioned in the literature when people start talking about surgery. They'll say, I use the Thomason dissector to remove the cholesteatoma from the attic. These are really, really useful. So I recommend, if you're going to make your own tray, get these or something similar to it. These are Storz, but I know Grace Medical, and I think the Panetti set, which is sold by, I have to look up who it's sold by, but it's the Panetti Instruments. I think they have a similar dissector, but you want one of these kind of angled, right angle, and then there's a sharp edge with a slight curve on the end. And those are like 2 different lengths. Those are just useful for getting on that bone and scraping cholesteatoma out of the attic or clearing disease off the lateral semicircular canal, things like that. And they have an angle on them. They're very useful. So I really recommend those, but you don't worry about buying a whole tray. That's too expensive. And suction round knives. These are, in my opinion, probably unnecessary. By the time you end up using these, like, you're kind of done with it. You put out what you do. What I usually do is you make your, if you're just doing an undersurface tympanoplasty, for example, you do your injection, you make your canal incisions with a sickle knife and a round knife, or whatever you like to do. If you like to use the different kinds of knives, but you make your canal incisions. And then what I do is I just elevate slightly with a round knife, and then I put a cottonoid with epinephrine on the flap and let it sit for a couple minutes, and that stops the bleeding, and then you can just proceed and you're fine. Suction round knives are okay, but they, if you're getting a lot of bleeding, I suppose it's helpful. But it's an expensive instrument for something that doesn't provide a whole lot of benefit. And actually, I don't like the Storz one here. The better suction elevator is made by Grace Medical. And there's 2 different types on their tray. One is the Rivas dissector by Alejandro Rivas. That's actually the one I like the best. There's also the Lee elevators, Daniel Lee from Mass Eye and Ear. He has a couple. They're actually better designed than this Storz one. The Storz one has the suction so that it'll grab tissue as you're elevating. It's actually not the best designed. The Rivas one has the suction straight, and then the sheath on top of it, the suction is straight, and then the sheath on top of it is protecting it sort of at a 90-degree angle. So the suction's forward, so it doesn't suck the tissue on the canal. It's actually better to get the Rivas elevator from Grace Medical if you're going to pick one instrument to have a suction elevator with. But I actually think that you really don't need these. I think these are, you can just use regular round knife to elevate and then put your cottonoids, wait a minute, put your cottonoids, wait a minute, suction, and then go in. If you're facing a lot of bleeding, these can be a little bit helpful, but it's not the first instrument I would get. I would get Thomason's first, and I would buy endoral retractors first, and then this might be the next thing. I would get one version of one of these elevators. And I mentioned Grace Medical has their own versions of these Thomasons. You can see these are the Thomasons here. They have their own suction elevators, the Rivas and the Lee. And then this is the Panetti set from, it's distributed in the US by GEDMED, and it's made in Germany. And they have these different instruments you'll see that are like these sharp scrapers with suctions. I've never used these. I've never used an instrument like this. I think the storage tray actually has some of these too. I don't find these helpful. I don't, and I'm looking for a reason I would use one of these, and I can't really find it. They're saying they're using it for the sinus tympani. Well, I suppose, but I would just use regular, either a Thomason or a Crabtree, elevate whatever you're elevating, suction it. And then I like to, in the sinus tympani, I like to take a dry cottonoid and put it in there and actually scrape and kind of scrub once I've cleaned out the disease. And then I look with the straight 0 or a 45-degree scope or 30 and just look again and make sure everything's clean. But I've never used these sharp, pokey ones. I don't find a great reason to have these, but I suppose if you have money to burn, you can buy some of these, but I don't think they're that helpful. Things that people talk about a lot are thermal injury. So I think in the early days, some people brought in some scopes, sat there for quite a while, and they got some either facial nerve issues or something else happened along the way. And I think what people have learned is you want to set your intensity of your scope low. So usually I don't have if I'm using a Storz or a Stryker system, I usually have it at 40 or 50%. The suctioning that you're doing will cool as well. And then intermittently you can irrigate with a bulb syringe, just flush out the ear. When I took the course in Switzerland, I actually asked Professor Prezzuti whether he thought that intensity of the scope made a difference. He's like, nah, only one person in the world talks about that stuff. But so he didn't seem very concerned about it. But I think generally it's a good idea to set your intensity low just so you won't have any problem with that. And I've never had any issues when I've set my intensity low. You don't get a lot of benefit lighting wise from 50% to 100%. You get a lot more heat, I think. And I think the newer LED sources are better than the xenon, but just something to be aware of. Be careful about contacting structures in the middle ear, especially with an angled scope. So if you're not comfortable using angled scopes, you might go in and bump the stapes or something like that. So you gotta get comfortable with it. You can use a 0 for most things. The only thing you really need an angled scope for is looking into the antrum. The posterior recesses, you don't really need, you can see it with a 0. You get an amazing view because it's almost a fisheye at the end of that scope. And you get a good view with a 0. I mean, and so you can get a 30 or 45. I think if you're going to buy dedicated scopes, I would buy the Storz 0 degree, the 7220, which is the 13 centimeter 0 degree scope. And I would buy a 45 degree 7220. I think it's A, and I can't remember the part numbers, but it's the 13 centimeter ear scopes that are 3 centimeter diameter. You don't need more than a 0 and a 45. I wouldn't buy a 70. Most people are saying now just a 0 and a 45 is adequate for pretty much everything. In the early days, they had 0, 30, 70, just like for sinus. But I don't think you really get anything over, just having a 0 and then maybe one angled scope. You can get 99% of what you need done with a 0 and maybe a 30 or a 45. And most of the time, I'm just using a 0. You can get pretty much everything done. Once you have your attic defect and you're looking around the corner, that's an angled scope is helpful. I suppose if you're doing something, let's say, for example, you have disease that really goes into the eustachian tube or something and it's quite aerated, you could get an angled scope in there and look around. You do most of what you do with the 0. Just a couple comments about how to kind of approach things. You definitely want to inject. I know early on in this, people were talking about, let me just make sure we got everybody in here. People were talking about just putting like topical lidocaine on the drum and just waiting for 10 minutes or something like that. Or that's a myth. You can't use topical anesthesia for this, for hemostasis. You have to inject the canal just like you do on any other ear surgery. And I think it's better to inject the tragus. You want to inject the tragus for your cartilage and perichondrium. I try to inject from the concha and sort of go subcutaneously into the canal and get the vascular strip, the posterior part of the canal elevated. And then I go in and I do a couple more anterior injection, low inferior injection. But you do need to inject. And that key posterior superior vascular strip injection is really the most important. And you want to, I kind of come in from the concha so I don't get a bleeding point there. If you can do that, great. If not, just inject it like normal and then put a sponge in the ear canal for about 5 minutes and just let it sit there and dilate and dry out the ear. In fact, you get a lot of times taking a bayonet and just putting a sponge in the ear and just drying it out and dilating that lateral part is really helpful if you're running into bleeding or something like that. You do need to use cottonoids, like I mentioned, with 1 to 1,000 epinephrine. Trimming hairs of the canal, you do it in people where it's really bad. If it's not really bad, you don't have to do it. I mean, if you have, you can do it. You want to clean your debris. You want to rinse the canal. Get your settings right on your system. You know, just like anything, it's better to inject and then sit back and, you know, have a cup of tea or something while you're waiting a few minutes and then do it. You know, trying to go in right away after injection is okay, but it's better to wait a couple minutes and give it a little time. Most bleeding occurs during the elevation of the flap. Once you get that done, and once you're in the middle ear, and once you've used a cottonoid or two, by then pretty much things are dry. And I like making a long flap because you can, unless the ear canal is small, you're not going to run into trouble. And if it's really small, you shouldn't be using an endoscope only for that surgery anyway, probably. But a long flap's helpful because you get that up. If you have an attic defect at the end, your long flap will come over and then cover your fascia or perichondrium, and then it'll epithelialize that. So, like using long flaps, you can use a cottonoid and a suction elevator, or you can use just a cottonoid and a round knife and then suction intermittently. As I mentioned, don't open your epi till later on. Irrigate and use suction. Be patient, especially at the beginning when it's bleeding. Just be patient. Just irrigate. Put your cottonoid with epi, wait a couple minutes, change it, put another one, change it, put another one, give it a minute or two, and it'll calm down. Sometimes it's quite frustrating how much it bleeds, and I think it's just because you're looking with a scope, giving you such that big view of everything that you're doing it. If you need to use a speculum, you can. You can. I've done endoscopic cases through a speculum. I've done that. If you want to make an endoral incision and put an endoral retractor in, you can do that. You can also get your tragus cartilage through that incision if you want. So you can do it more than one way. So there's, like I said, there's more than one way of doing this. What to start with? I recommend. I think we've got everybody in the. I've admitted everybody. We got 31. I started with moringoplasties, and you know, no annular elevation. That's the definition of a moringoplasty versus a tympanoplasty, is that whether you've elevated or dissected the annulus or not. So with a moringoplasty, anterior perforation, small, just like you might do a fat plug or something for, do it with an endoscope. Get comfortable with it. If you want to use perichondrium and do underlay, if you want to use tragus cartilage with perichondrium, like a composite graft, as I call it, I like doing that. I did that a lot. But I do it as an underlay. So you freshen your perforation, you put your gel foam inside, you put your graft in, and then you spread the perichondrium out under the perf with your cartilage there. I'll show you a demo of that. But I did a lot of that way when I first started. I think I did most of my endoscopic stuff was just moringoplasty that was underlay moringoplasty. Tympanoplasty for posterior perforation. Attic cholesteatoma I would do after you've gotten comfortable doing tympanoplasties. And then posterior recess disease, or severe retraction, posterior retraction, again, should be done once you're comfortable just with the techniques generally, especially just regular tympanoplasties. Some people even argue you should put your tubes in with an endoscope to get comfortable with it. Probably no harm there. It's just additional muscle memory. You're just developing the muscle memory, and it's not a bad idea to even put tubes in with an endoscope to get comfortable with it. But I would say, and the other thing that I learned when I took the course was, so in my training, we rarely lifted, for an undersurface tympanoplasty, we would rarely detach the tympanic membrane from the malleus, rarely. And Professor Prezzuti does it every surgery. So, and I think that there is an advantage in doing that for endoscopic procedures for underlay, especially if your perforation is anterior to the umbo. detaching the drum from the malleus is really, really helpful. And the outcomes are equal. There's really no worry about not of lateralization or things like that, kind of an over-under technique. And so I would encourage you, if you haven't been doing detaching the drum off the malleus, when you start doing tympanoplasties, start doing that on some cases just to get comfortable with it, and then use that technique, and you'll see that it makes it a lot simpler. I mean, Professor Prizzuti can do an undersurface tympanoplasty using, well, I guess he uses that biodesign material, which I don't like using artificial grafts, but if you use an off-the-shelf graft, I mean, he does his surgery in like, it's 10 minutes, you know, I mean, it's just, he does the canal incisions with a bovie, which I don't do, like a needle tip bovie, elevates, detaches the drum off the malleus. Okay, gel foam, biodesign, you know, it's fast. It's fast. But I like using perichondrium and tragal cartilage. I usually don't use artificial grafts. I've never liked them. That's up to you what you want to do in terms of your graft material, but I find it's just expensive and not particularly helpful. We talked a little bit about what to start with. Consider taking a course after you've done some. So once you get some experience, the course can help show you some more advanced techniques. You get to work on cadavers. You get to do some exposures of like the petrous apex. You get to drill the middle ear better. So once you have some exposure to laryngoplasty and tympanoplasty, and you're thinking like, I'm going to start using this for cholesteatoma, I think at that point is a good time to take a course. It's better to get a little experience with it under your belt first, and then take the course once you've sort of decided you want to expand your repertoire into something a little bit more advanced. So I've got a few videos here. You can tell, you'll see that the video quality gets better over time because these were over several years, and some of the endoscopic equipment we had probably wasn't as good. So you'll see the quality gets better as we go along. But this is sort of like what I was doing. This is kind of bloody, so you can't see it very well, but this is an anterior perforation, putting a Crabtree in, freshening the edges. Well, it's really red, but this is a right ear. This is anterior perforation, just putting in this, and you'll see this even goes right up to the annulus. You can get away with that, especially if you elevate an anterior flap. This is putting in a composite graft with cartilage and perichondrium on it, and you'll see the perichondrium is lateral. So what you do, once you put the cartilage in, you spread the perichondrium out under the drum remnant. If it's up to the annulus, you can actually elevate a canal skin flap and then drape that down over that. And you can get away with a fair amount of things using composite grafts. This isn't the best video, but we'll move on to another one because there's some better ones. But this is the outcome with that. Here's the anterior repair there of that. Here's a laryngoplasty that nowadays I would not have done this. I would not do this as a laryngoplasty now. I would do a tympanoplasty, and with a formal, I would actually detach the drum off the malleus. Now, at the time, I was not doing that. So I said, I'm just going to do an undersurface laryngoplasty here. Kind of aggressive, but okay, there's a lot of ways of doing things. So freshen your perforation. And we're going to take our composite graft, which from the tragus, and then what you do with a composite graft is you trim the cartilage slightly smaller than the perichondrium, so the perichondrium is larger than the cartilage, and so that'll allow you to put the edges of the perichondrium under the remnant. So this is just some gel foam. Let's move this along here, and you can see putting in the graft, big graft. You know, again, nowadays I wouldn't do this. I wouldn't do it this way. This is my early days. So you see, you spread it under, and yeah, that'll heal. And it was an older lady, you know, but it's okay. This is a nice use of an endoscope. Just advance this on. So this is a second stage.
This video shows a left tympanoplasty with removal of cholesteatoma and ossicular reconstruction. The first portion of the procedure is elevation of the tympanomeatal flap, and here a cottonoid is being used in assisting in that process. Prior cartilage that had been placed at a prior operation is exposed.
Yeah, okay. I'm going to move along here because this was from a first stage
here to control bleeding. A needle is then brought in to elevate the cartilage off of the region of the bones of hearing, and on elevation of the cartilage, a cholesteatoma is seen.
I'm going to go back and move that forward a little bit.
There's still a small ball of cholesteatoma present,
You see the great visualization you get, though. I mean, you really, I mean, after doing this, you feel very
but the middle ear
confident
is
that you've cleared
inspected
the
and is
disease.
free of any other cholesteatoma.
There's a small pearl there.
Cup
So
forceps is again used to remove the second portion of cholesteatoma. And now the normal structures of the facial nerve are seen in the middle ear as well as the stapes. Confirmation of removal of all disease is performed by using suction and inspection. The prior placed cartilage graft is removed using scissors, and the eardrum is laid back down to confirm no large perforations have been made in the eardrum itself. The middle ear is packed using gel foam or gelatin in preparation for ossicular reconstruction. Here, a titanium prosthesis is being readied for placement on the stapes head, and initial flexion to lateralize the eardrum slightly more to allow for cartilage grafting. The prior removed cartilage graft is replaced in the middle ear, lateral to the prosthesis, for the cartilage graft, and full length coverage is ensured to verify that no additional grafting needs to be placed.
that's kind of a
Gel foam or gel.
this surgery is a good use of an endoscopic procedure. It's like an OCR where you're worried about cholesteatoma. You want to make sure you get it all out. And you can see that was a 0-degree scope. You can see into the posterior recesses pretty well. Now, given that person has already had some canalplasty work from a prior stage, but you can see a lot with a 0-degree scope, and that's the case over and over again. Cartilage tympanoplasty. Let's move this forward a little bit. You'll see some different techniques. This is just dissecting off the ossicular chain. This one was retracted onto the incus.
The middle ear cavities.
Whoops, sorry about that.
Stapes bone. The flap is further elevated and the middle ear cavity is inspected. The tympanic membrane is then laid back down to ensure that the perforation has been fully lifted off of the middle ear structures, including the ossicles or bones of hearing. The middle ear cavity is prepared for grafting. Gel foam or gelatin is placed in the middle ear in preparation to support the graft. And a cartilage graft is now harvested from the tragal area, or the posterior aspect of the front of the ear, and placed in the middle ear. And then the tympanic membrane is laid back down. Confirmation is seen that the graft is fully covering the perforation. And then gelatin.
So in this case, I used a cartilage graft because the posterior drum had been retracted on the incus, and I wanted to prevent further retraction. You could use a combination of materials, whatever you want to use, but in my opinion, this is a good case for a cartilage graft, which I tend to use more and more in my career than I used to. Cartilage is a great material. We're going to show this briefly. This is a stapedotomy. And again, kind of the difficulty with stapedotomy is the one-handedness of it. I can see examples, for example, cases where, let's say you're doing a congenital case or revision or a narrow niche or something like that, where an endoscope could be helpful in a stapedectomy. But for routine surgery, I don't find it particularly helpful. Some people do it every time, and that's fine. I just don't find it does any better for me, and I think that it's a two-handed surgery. But that's my personal take on it. Move on here. Cochlear implant electrode going in. You can use an endoscope to look at certain things if you want. Here's a sectioning of the tensor and tympani and stapedius for myoclonic tinnitus, which we don't do very often. This is not a procedure we do very often, but again, this is a nice example of
membrane.
Just the beauty that you can see.
In the middle ear, we see the tensor tympani tendon, the stapedius tendon, and other associated structures such as the malleus or first bone of hearing, the incus or second bone of hearing, the stapes or third bone of hearing, and the chordotympani nerve, which is related to taste on the front of the tongue. Here, the stapedius tendon is being sectioned with a sharp knife. And the separation is demonstrated. Second, the tensor tympani tendon is also sectioned with a sharp knife, and then a needle is used to confirm that the separation of the tendon and complete discontinuity. Following this,
There's no particular advantage of using an endoscope for this surgery over a microscope. It gives you beautiful visualization for teaching purposes. I think it's great for documentation. It's great. But it doesn't give you really any advantage. And I think a lot of times people ask, what's the advantage of an endoscope? The advantage is visualization for certain situations. And I think that for certain situations, the visualization is unparalleled. It doesn't solve access issues, but for visualization, it's quite good. And I think that you can it provides such good visualization that it even overcomes that negative of binocular, of not being binocular in certain situations, especially looking in for recurrent disease or clearing disease. This is an interesting case. So I saw this case report a couple of years ago from Japan. So we do most of our superior semicircular canal dehiscence surgeries. We do them middle fossa. We do some of them transmastoid. But we usually use a middle fossa approach to plug the canal in symptomatic patients. But this report from Japan was interesting because they use an underwater technique through the mastoid to do a occlusion of the superior canal, and they do it with an endoscope and an endoscrub. So they're doing it underwater, and I'll show you how this works. I've done this about 4 times. I've done it in a couple of patients who I didn't want to do a craniotomy on. I think one of them was anticoagulated. I think there's a slightly higher risk to hearing when you do a transmastoid occlusion because you're closer to the ampulla of the superior canal. So I think there's a slightly higher risk of sensorineural loss. But you'll see that this is kind of a neat procedure, and the visualization is amazing.
This video will demonstrate a left-sided transmastoid superior semicircular canal dehiscence repair performed endoscopically underwater using endoscrub for constant irrigation to prevent pneumolabyrinth. Complete mastoidectomy is performed.
So this is a left ear, and the reason you're using underwater is that the concern when you open a canal is you'll get air into the labyrinth, or you lose endolymph, perilymph out of the canals. So if you're using it underwater in saline, you're sort of protecting the labyrinth from it. That's the theory.
The semicircular canals are identified. Using a 0-degree endoscope and a 4mm diamond burr, the superior semicircular canal is blue-lined. This depicts the landmarks of the superior semicircular canal with its ampulated and non-ampulated ends. The ampulated end is opened first by exposing the endosteum with a 2mm diamond burr.
So the goal here is to create about a 1 by 3 millimeter fenestra on either side of the dehiscence. So the dehiscence is in the superior aspect. So you need to plug on both sides of the dehiscence to prevent the intracranial pressure from traveling into the labyrinth both ways. So you need to create a fenestra anteriorly and posteriorly, and then occlude it, which is as opposed to a middle fossa where you basically just plug it from the top. So it's a different technique.
Next, the endosteum is removed with a fine pick, taking care not to violate the delicate membranous labyrinth. The non-ampulated.
Let me just move on a little bit. So basically, once you've created the ampulla or the fenestra,
during mastoidectomy,
you plug it with fibrin glue and bone dust.
Harvested during mastoidectomy,
and you mix them.
Is mixed with tissule and fashioned into approximately 1 to 2 millimeter plugs, 3 of which are inserted into the canal opening, effectively sealing it.
So we're going to go to the other side, do the same. And this is all done under saline, and it's just a standard endoscrub that you would use for like a sinus surgery. You do have to turn the irrigation really high. I think it's like a 5 or a 6 on the endoscrub, because otherwise you'll get a lot of bubbles. We kind of learned you really have to prime your tubing first so you don't have air in it too. It's another issue, but this is basically, you'll see the blood floating through the water here. You know, this is all done under saline, and the visualization is amazing. I mean, it's like doing it's like a knee arthroscopy. I mean, you can see everything really well. And once you plugged it, then you take fascia and just put fascia over this and some gel foam, and that's it. I mean, you're done. And so this is actually a really nice way of doing a transmastoid occlusion. You just put fascia over it, and that's it.
This video.
I think we're about out of time, but I don't know if I have this is an older video, but just demonstrating you can use cement to reconnect the ossicular chain.
Then allowed
So
to
we use
harden.
mimic cement to refuse the chain. And again, it's a little older video. The video quality, the worse the quality, the older the video for the most part.
Just in the middle ear to prepare down.
So that's just another example of using a scope. But basically, that's kind of the introduction. So for those of you who are starting out in this area, I would encourage you to start slow. Start with laryngoplasties. Start with tympanoplasty. Maybe start with tubes, and then once you get comfortable placing grafts for those procedures, and you want to move on to cholesteatoma work, maybe consider a course at that point, and then just venture into it. I don't have any problem saying that I use a microscope when I need to. I mean, I think when you're learning a new procedure like this, you don't want to take the attitude of, well, I'm going to use this for everything, because that's not really appropriate. I mean, it's really an additional tool. It's fun to do. It's fun to do because the visualization is so good, and you are avoiding an incision, so to speak. But don't hesitate to convert to a microscopic procedure for mastoid disease. I mean, just don't hesitate. You'll never regret converting a patient for mastoid disease and using a microscope, because the nice thing is, by the time you've gotten the endoscopic work done, you really only have the antral disease, and that goes pretty quick. I mean, you just make a postauricular incision, go in, drill the mastoid, get down, clean the sac out of the antrum, and then you've already done the rest of the dissection with your endoscope. So it's not a lot of extra time, but the confidence you get by doing that is a lot higher. You get a lot higher confidence that you've removed the disease, and you'll be much happier in the long term if you do that. So don't overjudge what you can accomplish with an endoscope. So I would say that, aim low and perform high, but don't think an endoscope will get you past complex issues like a small canal or disease that goes into the mastoid. It just won't surpass those obstacles for you. You just still have to manage those with a different technique.
Well, Eric, listen, interesting topic. Like I said, it's on the frontier of everybody's profession right now in otology. I thought that video of the superior canal plugging transmastoid was really beautiful. Your comments, I read that paper, and you really brought it home for me. Just one observation, because I only use endoscope for diagnostic purposes at this point. I just, most of the disease I'm seeing is just much more aggressive, as you're aware of, in the work environment we are at. But one of the things I've seen is that a lot of people do excessive dissection. Do you have any comments on that, or is it just because the visualization is so beautiful that they kind of just get carried away with dissecting tissue planes and elevating more of the canal than they might need to?
Well, I think let me answer your question in a slightly different way. I mean, when in the few years ago, one of the pros that was put out there for endoscopic procedures was that we would reestablish the normal aeration pathways in the ear, right? So you go in and there's disease there, so you clear an obstruction, and now the air can flow back from the eustachian tube through the Prussac space, through the normal to reestablish aeration. Well, you're not, I mean, there's not really that many cases where you're reestablishing the standard aeration and preserving membranes. You're pretty much, when you have disease that requires surgery, you're going to go in and you're going to remove the disease and the ossicle involved and the membranes involved. And yes, you want to clear the eustachian tube, but it was put out there like, oh, we're going to magically reestablish the normal route through the membranes. I think this is, I mean, it's a beautiful dissection, but it's not a realistic clinical goal, because by the time someone needs an operation on their middle ear for cholesteatoma, unless it's very small disease, you've gotten beyond that sort of preserving membranes aspect. Yes, of course, aeration is important, but we're not going in there saying, well, I'm just taking off this cholesteatoma from right here, I'm leaving that membrane intact, and then and then I just have to clear this membrane, and then things will come through. That's not how these surgeries go. You don't go in and magically restore the mother nature's anatomy. You go in and you clear the problem. You remove the disease and you establish aeration, but you're not sort of preserving these membrane structures like is talked about. And that's one of the things I remember hearing about this. Like, we're going to go in and we're going to restore normal aeration. I'm like, well, if they've got a 2 millimeter cholesteatoma ball or something in there, or a granulation tissue, and all you have to do is clear that, and then you have to clear a membrane, that person's probably not most of the patients we're operating on. I mean, most, like, for example, next week I have a patient who has about a 5 millimeter middle ear cholesteatoma, Pros-X-based cholesteatoma, but pretty much guaranteed that person's going to require their malleus head to be removed. The incus may have to be removed. I may be able to preserve the normal chain, but none of those other membranes are going to, like the posterior malleolar ligament's not going to be maintained. The membrane between the facial nerve and the incus is not preserved. We're not preserving any of those normal membranes. We're removing all those membranes. We're going to take the disease out. We're going to fix the drum. If the chain's intact, I'll preserve it. If it's eroded or there's disease on it, I'm going to take it out and put in a prosthesis. So you don't change your operation and magically restore. But I agree. I think that there is a role, though. I think it has helped us understand the anatomy better. I think middle ear anatomy is better understood when you can view it closer. But I don't think that you have to make the distinction between what we do, like in a course, like just to dissect a middle ear and say, here's a beautiful, this is the fustus bone. Oh, well, I've never heard of that. What is the fustus bone? Well, the fustus bone is at the base of the cochlea, and it goes down to the stylomastoid tip and goes down to the styloid. That's amazing. But does it actually matter when we actually do the surgery to know the fustus bone is what the fustus bone is? Well, to some degree, but it doesn't change the operation that we do. So there's a difference between demonstrating anatomy and then just dealing with disease. And so it's not like we're doing something preservation-wise with an endoscope that we wouldn't do with a microscope. We're not doing a different operation with the endoscope that we do with a microscope. We're just seeing what we're doing better, maybe. But the operation's not different.
I appreciate that. Eric, there's two questions. One was, what's the thickness of the endoscopes? Are you using 2 7s, 4s, 3s,
Yeah, I mean, so you can use, what I would say is this: if you only have 4 millimeter sinoscopes and you want to start using those, no problem. In fact, I did a fair amount of my surgeries with 4 millimeter sinoscopes, the long standard sinoscopes, for a long time, because I didn't have endoscopic ear scopes. The best scopes that are adapted for the use in the ear are the 3 millimeter Storz 7220 or the equivalent from another company, but it's basically a 3 millimeter by 13 centimeter scope. But you can use sinoscopes. I've used pediatric sinoscopes, like 2 7s. I've used 4 millimeter sinoscopes. I've used, like, if you have a big canal, you're going to get a much better view with a 4. The quality of the image with a 4 is much better than a 3. For as much as Storz would like to say it's equal, the 4 is better. And so if you've got the room, no problem using a 4. You don't have to buy special scopes. You can use your sinus instruments for this. And then later on, when you get more experience, do more cases, and you have the funds to get the 13 centimeter Storz ones, those are ones I would go to. It's the 7220 series from Storz, the ear ones.
Okay, and then the other question was, but I think he says, why do you cut the tensor tympani tendon during sleepy surgery?
That wasn't stapes. So there was that was a sectioning of the tensor tympani and stapedius from myoclonic tinnitus.
Exactly.
But I will say this: during chronic ear surgery, it's pretty common to cut the tensor because, and I showed this, and I kind of skipped over it a little bit. But in the case where I was putting in the prosthesis, in order to lateralize the tympanic membrane better, cutting, if you still have a malleus there, cutting the tensor gets your drum more lateral and gives you more room to put in your prosthesis. And sometimes with tympanosclerosis, the tensor is fixed. You'll have a scarred tensor tympani, calcified, anterior malleolar ligament will be calcified. So for example, Antonio Dela Cruz would always, first thing you would do if you thought your chain was stuck, the first things he always taught you to do were to cut the tensor and then cut the anterior malleolar ligament. And by doing those two things, and that's just a one knife, sickle knife up to the scutum, anterior to the neck. Those two things will mobilize a malleus like 90% of the time, just doing those two things. If that doesn't mobilize a malleus, you probably have like such a stuck head or something. You're gonna have to take the head off. But for tympano, that's gotten. I mean, I can't tell you how many times I've cut a tensor and anterior ligament on a chronic ear, because I always hear Dr. Dela Cruz's voice saying, "Cut the tensor and the anterior ligament," and it helps. It's something you'll see. Oh wow, everything's moving better. So that's a good way just to mobilize lateral chain. But you want to, if you're going to do a lot of work on lateral chain, you want to separate the incus from the stapes first. Like if you're doing it for congenital reasons. In chronic ear disease, a lot of times it's already eroded, but for diagnostic purposes, in a chain fixation, I like to separate the incus and the stapes first with a needle or a knife, and then I go to town on the lateral chain. You can cut the joint, you can cut the tensor, you can mess with the joint, you can cut the ligament, you can start like leveraging them, trying to get them to move, but you want to separate the stapes first, just so you don't injure the inner ear.
I think the last question is, how thick a coronal flap do you use? I think it's how long a conchomeatal flap do you make?
Mm-hmm. So for example, the flap in the tympanomeatal flap on an endoscopic case, at least 4 millimeters from the annulus, because 3 or 4 if you can, at least 4, because for the most part, you're not going to run into problems with putting your flap up anteriorly. And like I said, if you're dealing with such a small canal that's going to be a problem, you're probably looking at having to do an anterior canalplasty anyway. So I usually use about a 4 millimeter long flap. Now, if I know I'm taking out attic cholesteatoma, I might even make it a little longer, because what I want a really long flap. So when I finish the middle ear work, because you usually have to cut off the pars flaccida usually is gone. So you have your pars tensa and a long flap. And then once you've done your middle ear work and your attic work, then you put in your recon, either your cartilage, your gel foam and cartilage, and then you put your perichondrium or your fascia, and then that flap lays over everything and just nicely covers it, and it's going to epithelialize everything. So in those cases, attic cholesteatoma, I like a long, it's almost like as long as you can make it. It's not all the way out to the meatus, but it's a long flap. As long, you have to make a judgment on how much tissue the ear canal can support and sort of store up anteriorly. But I would say err on the long side. Err on at least 3 millimeters, of a long flap, even sometimes 4 or 5, depending on what you're doing.
Okay, and then what do you do if you have a lack of skin after tympanomeatal flap? We just talked about that. You put perichondrium or fascia and do it. That's why when I do my stapes, I like long flaps, because you don't know how much scutum you're going to have to take down.
Yeah, and actually, if you end up with a short flap, which is pretty common when you're doing attic cholesteatoma work, you're always going to have a defect. You're never going to have enough drum. So you're going to use tissue. You're going to use perichondrium, fascia, combination. Don't hesitate to use multiple pieces of things. You can make beautiful patchworks. This is where some of those techniques from that TOS book come in, because there's beautiful drawings and diagrams of how to do recon of the attic. He'll put in, cartilage in one area, then he'll put fascia and perichondrium. He'll put different cartilage carved in different ways. You have to have some concepts of different ways to reconstruct the attic if you're going to be doing this kind of thing. Because if you're doing endoscopic work for cholesteatoma, you're going to spend a lot of time reconstructing the attic. I mean, that's going to be your, once you get the disease out, it's like, all right, I got a big hole, I got to fill it in, I got to reconstruct it. And you have to have different methods of doing it. You have to be comfortable using cartilage, perichondrium, fascia, combination of those things. And like I said, I prefer not to use artificial grafts, but I mean, I don't have a problem with people using them, but I mean, believe me, I've had the reps come and try and sell me those things, but I've just avoided using artificial, because patients have plenty of tissue. You can even go to the other side if you have to. If someone's had so much surgery, go to the other ear and take a nice piece of fashion, go over the other side. I'd rather do that actually than use artificial materials. But
Okay, I guess the last question that I'll ask is, do you believe the beginning endoscopic ear surgeon should be able to have adequate knowledge and use of the microscope to do the procedure prior to using an endoscope?
I don't think they have to have an expert level of proficiency, but I think they have to have, I think you have to be comfortable using a microscope. Like, you have to be comfortable with its mechanism, comfortable using it. You should be able to use a microscope to do a tympanoplasty. I mean, anyone doing ear surgery for any reason should be able to do sort of basic fundamental things like putting a tube in the eardrum, doing a post-auricular undersurface tympanoplasty using a microscope. That should be a skill that everybody has, even general ENT doctors, okay? If you have the ability, and a mastodectomy to take out infection and cholesteatoma, you should have that ability. You may not need an expert level of skill, but you should have an adequate level of proficiency with a microscope. And because if you don't, you're going to have to refer patients out. I mean, you're going to do part of it, you won't remove all the disease, and then you're going to refer because you can't handle the rest. So I think it goes hand in hand. As you develop as an ear surgeon, you should be doing both of those things. I think there's a danger a little bit in people saying, well, I'm going to use just all my endoscopic equipment for ear, and I won't do any, I won't use the microscope. I don't know if we'll ever reach that era. I don't think that's feasible, even with these exoscopes now. And I mean, that's kind of I think that's a little bit of a, gimmick, but you need to have an adequate level of proficiency with basic tympanoplasty, mastodectomy techniques with a microscope if you're going to be an ear surgeon at all. And I think you have to have have an adequate level of proficiency with it. It doesn't mean you're never going to refer patients out to some other doctor, but you should have an adequate level of proficiency.
Eric, listen, very enlightening lecture. A lot of good pointers here for everybody kind of experience. And
Thanks, Richard. You're cutting out a little bit, but I think we're concluding. So I'm gonna go ahead and close the lecture. Bye, everybody.
Thanks. Goodbye.
Bye, bye, bye. Thank you.
If you have any questions about stuff, feel free to email me. My email is ewilkinson@houseclinic.com. So it's EWILKINSON@houseclinic.com. If you're interested in, if you're thinking you want to do endoscopic stuff and you're curious about an instrument or something, just let me know. I'm a big advocate of just using what you have and then slowly expanding your repertoire. You don't have to go, invest in a lot of instruments for this. You can use what you have.
Okay, thank you very much.
Okay, thanks everybody.
Thank you, Eric.
Thank you.
time.
Thanks for spending an hour with us.
Yeah.
We got people from all over here. It's great. Thanks, Richard, for putting this on.
Okay, thanks, Eric. I hope I'm having a little trouble with my connection, but again, I hope you can hear me, and thank you for your time, Eric.
Thanks, Richard. Bye-bye.
Okay, bye-bye.